Hey, Cam followers. So we have a few little breaks in this just because of the overload on the internet. We're talking about multimodal management. And we were saying that a lot of people don't realise they already do it. Now, I'm very into non-drug interventions. I'm not scared of medication at all. But I really feel that people should use the non-pharmaceutical interventions as much as they do the pharmaceutical. And I'm just going to demonstrate it. I've got quite a bad back at the moment. And instead of me choosing medication, I've been up, moving, I've been out for a run, I've done lots of stretching and some yoga. I've been making sure that my bed is correct and comfortable. I've chosen positions to sleep in that are comfortable. I haven't gone straight to the pill pot, and actually I feel much better. So multimodal is about using lifestyle, pharmaceuticals, maybe nutraceuticals, and complementary therapies. So let us begin. Where do you want to start, Karen, with the whole multimodal? Do you want to pick your topic?
Well, I mean, I think you're right. I mean, thinking about trying to use something that is potentially not a drug first. And I think one of our issues is sometimes when we diagnose, sort of, and sometimes when by the time they get to the vet, it's beyond the stage where we may be able to just do non-drug. Mm-hmm. But if owners are thinking about it, or if they know that their pet does have the days where they're not great, then thinking about maintaining their exercise, maybe swimming, all of this sort of thing, I think is really important. I think probably a big thing for me, I had my first Labrador. He was 9 months, he had hip x-rays, and the radiologist said there's evidence of him having issues, having hip dysplasia. She said, well, I sort of asked for some advice and said, what should I do? And she said, well, main thing is just to be consistent. And I was always very aware for him that maintaining his muscles, so giving him good exercise, but not overdoing it, maybe making sure he's swimming, keeping him slim. I've had a lot of Labradors in my life, and some people actually ask me what breed they are because they're so slim. Mm-hmm. I am an absolute fanatical about keeping my dogs.
Yeah, I am too. I get told that Luna's too lean, and I'm like,
yeah, no. So I mean, I think, and that his name was Lester, and he in the end had another condition towards the end of his life, but he never showed any signs of lameness until right near the end. And I'm absolutely convinced that's because everything else that we were doing with him, exercise, swimming, he did quite a lot of swimming, keeping him slim, all meant he didn't progress, or he didn't have maybe not the pain, the discomfort that needed treating with other drugs. Obviously, I would have given them to him if he needed them, but trying to steer away meant that when he did need them, he could have them, and it wasn't always long term. So, and I think sometimes trying to make people think, well, we may need drugs for a short term, but then still it's always the lifestyle stuff that's going to keep them going for longer.
Yeah, and I think that's a really good just little tangent to go down and make everybody realise that this is a team effort. If we're really challenge arthritis, not just today, not just this year, but for the next 10, 15, 20 years, we've got to realise it's a team approach. So we need to have owners that are more aware of how animals express pain, so that they are vigilant to the first indications that the dog is struggling. We need them to trust the veterinary profession and feel that they can come to us with the early signs, knowing that we can help them and they're not going to get tied into expensive drug regimes or feel that they don't have choice. If that starts to happen, we can explore lifestyle change with the intention of pain control, improved function, longevity. Whereas at the moment we've not got that, and it's no one's fault, but personally I feel there's a little bit of a pickle we've got into where owners don't detect it early, when they do detect it, they're a bit in fear of doing anything about it. So they do a little bit of bury the head in the sand slightly, which is understandable. And then, unfortunately, by the time these cases do come to us first opinion practitioners, they're very progressed. And now that I work with nothing but musculoskeletal disease, I'm always surprised at how well dogs cope with quite significant pain. And I just walk in and I start palpating and I start examining them, and I'm like, he's really painful. Owners are then really shocked, and so it's a real team approach. Owners got their role, we've got our role, we can really change this. But let's go back to the truth of the situation. In your world, in my world, we do see them quite painful, don't we?
Yeah, and I think often when they come to us, then it is the time at which we say, well, actually, we do need to give them some anti-inflammatories, maybe something in addition. But my aim always is, if we then can get them back on an even keel, then we can bring everything else in, and we can get them moving, we can get them maybe doing something like acupuncture or massage or something else, because they're all, I always extrapolate back to us. These are all things that I do for myself. I don't take painkillers all the time. I don't want to if I can. And I think just trying to sometimes getting them over that hump of a real problem. And some of them do have to end up being on treatment all the time, and that happens as they age, definitely. But if we can, and what I say to owners is, if we can minimize the amount of drugs that we've got your pet on, and then we can save them for when there is a bad problem, and then we can get that, we've got somewhere to fall back on. Because if we don't do the other things, then we're relying on the drug therapy as such, and essentially it gets used up quicker because we've got nowhere to go. So
well, I think you've just highlighted another little tangent, and so I just went and did some lectures over in New Zealand, which was awesome. Some lovely owners, nurses, and vets. But a topic that did come up was, why do vets end up putting dogs on long-term non-steroidals? And again, I really don't feel that any particular party is to blame. As a vet, as a first opinion practitioner, when I see someone's dog, my intention is, first priority is the dog, and then priority is the owner. And if the dog has come to me and I know that he's quite painful and the owners have probably not picked up on it for quite a while, I feel my duty of care is to the dog, and I would probably suggest longer term anti-inflammatories than maybe with another owner that was hypervigilant and had picked up on the early sign. So in defense of a lot of vets that are seen to prescribe long-term non-steroidals, that we do know that they work very effectively if given long-term, potentially more effectively at the lowest effective dose, but also there is that worry that the owner's not going to pick up on deterioration, and our duty of care is the welfare of that dog.
So they probably, I think so, because I think, and also maybe a lot of vets aren't very confident, and they would rather err on the side of making sure that their pet is comfortable than not. And also maybe having somebody having to come in for repeat prescription checks, they can actually check on that pet as well, because it's not easy sometimes. I think dogs are really good. Cats are brilliant at hiding it, but dogs are really good at hiding things in general because they want to please us and they want to carry on doing. And also, if you see something every day, you don't see the incremental changes.
No.
And it's sometimes when you put them back, you put them on some medication and they all say, wow, that's amazing. For me, I work in a clinic that does mainly eyes now. I do pain relief as well, but we have this with patients that have increased pressure in their eye, and one of the things is, unfortunately, we end up having to take their eyes out because we can't control that. And the number of owners who say after the surgery's gone, I've got my dog back. completely, and because it happened over such a long period of time that the changes happened, that they can't, you just don't see it. As a human being, we find that really difficult to see, say, well, actually 3 months ago, maybe they were doing this. And it is difficult for people, and you've got busy lives.
Yeah, and I think that's another really good thing. I'm really a big advocate of non-steroidal trial, and I have a really good conversation. We have a discussion about it. It's going to be good 4 weeks, and we're going to look at what is possible.
Yeah.
And I quite often will say to people, well, then that's the benchmark that we need to achieve with our other non-pharmaceutical interventions. So if weight loss and controlled exercise and stopping throwing the ball and jumping out the back of the car and all of those things that exacerbate the condition, if changing that leads us to that level of pain control and that continued happy state, physical capability state, if we meet that, great. But if we don't, then we need something to help us keep. So
another thing, sometimes, I mean, it's similar to your trial, but sometimes actually removing treatment. This is something I know that one of the universities in America has looked at, that actually humans much better at seeing a negative than they are at seeing a positive.
Yeah.
So if, like after your trial, the owners are like, oh, I'm not really sure if it has or not. Sometimes actually saying, okay, if you don't think it is, but when they stop it, they see that there is a deterioration, then that's almost a reinforcing thing as well. So, none of us know what particular treatment regime is going to be the right for that dog. And I think that's also where it's difficult, because it's not just a tick list of what we have to do. It's what each individual patient needs, and also what each individual owner can manage.
Yes.
Some owners are not going to be able to go swimming with their dog 3-4 times a week. Others will absolutely, they can do that. But I think it's trying to manage the two things, looking after the dog or the cat or, their pet, and then trying to fit into their lifestyle as well.
Yeah. And we talk about the biopsychosocial thing. I was listening to a physio podcast, and that's quite a new term for me. I hadn't really heard of it in the vet world, and it was in the human world. And it really does apply to this disease, because, you could have 3 Labradors that are like from the same litter with similar condition, but they're with different owners, and there will be different management plans depending on the owner as much as the dog. So it's very complicated. So when anybody ever says to me, are you still interested in arthritis? Haven't you got over that yet? No. Because it's huge. So on that note, let's go on.
Carry on.
Okay, so first port of call, non-steroidals. So we're going to pharmaceutical multimodal management. Tell us about it. Hopefully allay some people's fears, etc., etc.
So, I mean, we all take non-steroidals, quite often. I think that's the ibuprofen group of drugs. Now, the ones that we use in our pets are not the same. They're slightly different. And these groups of drugs, it's important that only the ones that are meant for that species are used. So it's some drugs we can transfer between mammals, like dog, cat, human, horse, but non-steroidals are a little different, and cats deal with them in a different way to the way dogs do, a different way to the horses, so all of that. So we need to be really careful that we use the one that has been properly tested. That's always an issue, because I do have a few people who want to give some Nurofen to their pet, and we definitely would not recommend that, or aspirin. So the basic way that they're working is trying to reduce some of the inflammation. So what we see in that sort of, in that arthritic joint is there's lots of, I suppose the way we would describe it to, you know, sort of lay persons is swelling, but on a microscopic level, there's lots of things going on, being released that make that inflammation worse.
Yeah.
So the non-steroidals tend to reduce that, and that's sort of a basic way of way they work. They can also be sort of what we call classic painkillers, but a big thing is it's you know, it's reducing our inflammation, and that's what we all think of them, I think, isn't it?
Yeah. Quite often I talk about the inflammatory soup in the
yes, yeah.
And then I found, again, to owners by saying that that inflammatory soup was quite spicy and it was winding up the nerve receptors that transmit pain. So by quelling and calming that soup down, we stop those nerve receptors discharging and sending messages of pain. But us vets, we're quite confident using non-steroidals. You know, I'm not worried about using them. I use them a lot. There's a big fear about using them. I've got my strong opinions about this. I think there's a lot of people jumping on the bandwagon because it sells their product by making somebody fearful of another one. But what do you think about using non-steroidals?
I mean, for me, they're the first line. And they're, as much as any drug can be safe, they're safe. I think one of the issues is, like in humans, they're one of the most prescribed drugs. So we're going to see new side effects. And because there's more people giving these type of drugs to their pets, the more we'll know about those side effects. And unfortunately, there's not in this life, there is always some risk with things. The main thing with these drugs is that we try and minimize risk. And the vast majority of pets will not have an issue, but I give them to my own pets if they have pain. And that's the only thing I can say to make people feel better about using them. I am like the most paranoid owner in the world. I was like, I'm an anaesthetist and I get stressed about anesthetizing my pet. So, you know, like...
Yeah, put it like that. If Luna needs them, I've got a bottle of Metacam up in the bathroom, and if she's done something and you can see the hoppity lame, I use it. And Holly was on Metacam for a couple of years. You know, if they need it, I don't have a problem.
Yeah, no, and I keep an eye on them to make sure that they're not having problems. I've got a pug for my sins, who is adorable, but he's not got the best intestines in the world. So I'm always really looking at him if I have to give him Metacam. I noticed today he's pulled his toenail. So if he starts being sore, then he's going to need to have he's going to probably have a day or two of Metacam. But I would keep an eye on him, make sure that he's not having an issue. And if I'm really worried, then sometimes I will give other drugs to help to protect tummies and things like that. But,
that's a good topic, because a lot of people would like to know more about this. And I know that there isn't a set plan. There's people with different opinions about this, about using gastric protectants alongside. What's your thoughts on it? Because I know there isn't a definitive rule.
Well, I mean, I think that's the problem. I think there isn't. But what I tend to, if I have a history of maybe like with my pug, he does this regurgitating and he generally has a very sensitive tummy, then I tend to give them something like, I don't know, omeprazole or something like that. He can't take omeprazole, as it happens, which is why I hesitated. He's a disaster. But if it means that I can treat them probably for a short period of time with that drug, allow that, then I will. If there are absolute what we call contraindications, so reasons why we shouldn't give those drugs, then I will start to think about something else. But we have more information about the non-steroidals than we do about any of the other drugs. So for us, it's much better to stick to the drugs that we know something about first line and alter things as we need to.
Yeah, I know that with the gastroprotectants, it comes up a lot on Holly's Army, because people in the human world, and it's very common, if you're going to be put on an anti-inflammatory long-term as a human, they will put you on a gastroprotectant. So people think it's just commonplace that we should do the same with our pets, but we are physiologically slightly different.
Yeah.
As owners of our own sensations, if we're feeling unwell, we're the first to pick up on it. We've said earlier, dogs are very good at coping. And I know that there are some people that fear that by using gastroprotectants, you're potentially pushing potential pathology further down the intestinal tract. So from it being a gastric ulceration-y type gastric upset, we could start getting intestinal upset. Have you experienced that?
I mean, not so. I mean, I've done lots of, well, not lots, but quite a few anaesthetics where I've had to do the anaesthesia for a pet that's had a gastric ulcer or an intestinal ulcer. I don't really have any sort of evidence either way what is the issue, you know, whether they were on gastroprotectants or not. I have this feeling that some dogs, not so much cats, but some dogs are just predisposed. They will just have an issue with it. And I don't know that we know enough about it to say which ones are going to be a problem and which ones aren't.
No. And the sad thing is that being in our position, I'd say 95% of the dogs I prescribe an anti-inflammatory to are going to be brilliant, and their life's going to be better, and they're going to have a good quality of life for a really long time, and the bond is going to be reignited between them and their owner, and it's a perfect decision. But every now and then, as you say, you prescribe it and it doesn't work for that owner and dog, and it's a very difficult conversation to have because you've done it with the best intentions. Yeah. Is disappointed with the outcome, you know. Yeah. So the take home for the non-steroidals is that on the whole, you know, they are an absolute game changer.
Yeah.
They don't necessarily need to be long term. A lot of people think that it's just a long that's it for life. No, get your lifestyle sorted, get your home management, get your weight off, get the complementary therapies in. Don't throw the ball, don't throw the frisbee. Think about the common stuff, you know, and then you could potentially find that you're coming off of the non-steroidal.
Yeah. And that's always the aim, if you can.
Yeah.
You know, I think it's just having that goal of reducing therapies, especially the drug therapies where you can.
Yeah.
I would say, yeah.
And I think the public have got to realise that our priority is controlling pain. These are little take-home messages. Not knowing your dog, not seeing your dog and watching them walk in, quite often we'll see that your dog's coping more than you realise. For us, and, you know, making us animal lovers, we're animal lovers too, making your dog as comfortable as possible, as quickly as possible is our priority. And we're going to choose something that we trust and we've got a lot of info on. Let's jump over to paracetamol. I was amazed when I was over in Kiwi land. They were like, paracetamol, and I'm like, I quite like it. Do you use it much?
Yes, yeah. I mean, I've seen the whole thing. So I qualified in '94, and we had Pardale still then, and maybe there was a bit of paracetamol, but people really didn't really talk about it. And then it's sort of almost coming completely. Some people are using it as a first line, which I wouldn't necessarily always do, but I always have it on my side that if either a non-steroidal doesn't work, maybe I add it in or substitute, or if a patient really can't tolerate non-steroidals, then I think about it. But I think now it's going to be my second thing that I think about, because I think it's, well, in dogs, obviously not in cats. We don't want to use paracetamol in cats.
don't use it.
But it's certainly something that seems to work really well. The issue is that what we know research-wise from an academic point of view is not as much as, say, non-steroid, as like the classic non-steroidals. But I think for me, I've seen dogs do really well on it. And if it means that they carry on and having a good life and can, you know, go for a walk and do things like that, then that's absolutely, for me, the goal. And
yeah, so I tend to use it for flares, so I'll add it to a non-steroidal for a flare for a term, or I'll then use it as an adjunct more in a long term if I needed to, or if I've got a dog that I may be swapping non-steroidal to another non-steroidal, I use it in that period. Or if I've got a dog that's managed to eat something on a walk and it's upset its tummy and then can't be on the non-steroidal, so I'll use it in the interim. So I personally find it quite flexible. Do you feel the same about it? Or?
Yeah, and I don't think you need to do, often, like you were talking about just there, when you're changing non-steroidals, it's like what we call a washout. So we want to get rid of one in the body before we give it the other. And that we don't seem to have that issue with paracetamol. And I think that makes it, like you say, quite versatile. Works really quickly, as far as I can tell as well. So giving it for short periods of time is also an option. So, I mean, other drugs sometimes might take a bit longer. And it's fairly innocuous. You know, it doesn't make them sleepy by and large, which some of the other sort of drugs that you go further down the line do, and that's a bit of a balancing act. So I think that's important also, because that affects their quality of life.
We use it a lot IV now, and I just a little anecdote, N=1 story. My brother-in-law had a big car collision, and I had to go and sit with him in hospital. He was all strapped to the bed, so he had cushions either side of his head and the strap going across here and here, and he wasn't allowed to move. And until he was assessed by the doctor, they hadn't given him any pain relief, so he was really very uncomfortable, and he was beginning to get to that breaking point of, I need drugs. And a nurse came in and popped something into a drip line, and you could just see him completely relax. And I said, oh, was that morphine? And she was, no, paracetamol. And it was, wow, you know, and he was like, oh my God, that's just amazing. And he couldn't see her put it in the drip line because he was strapped down to the table. He was like, what have they given to me? That's amazing.
Yeah, I think we underestimate its pain relieving properties.
Yeah.
I think we're beginning to realise it more and more, especially chronically, but also in our operation patients as well.
Yeah, we use it quite a lot. Okay, so what would you use after that? So we've had a dog that has been on maybe Previcox or Simuljex or Rimadyl or Metacam, whatever, because all of these, every dog responds slightly differently. And you've been using paracetamol a little bit for your acute flares, but you're now beginning to go, do you know what? We need more. What do you start looking for?
So this is where it all becomes very personal opinion. I think I'm a gabapentin person. I'm not a tramadol person.
No, that's fair.
Mainly because I've used it in my own pets a bit, and it seems to work quite well. It doesn't suit every patient, definitely doesn't suit everyone, but just a few where they can be quite sleepy the first few days, but that often will wear off. And I really tinker with the dose a bit to try and get it so that it is, you know, so that they actually can cope with it as well, that they aren't being sleepy or a bit wobbly on their legs or anything. And it makes sense to me. It makes sense that it works. Like you were talking about that sensitizing soup. What also happens is that further up, where the spinal cord and the brain are all interacting, and it sort of makes us overreact, not sort of consciously overreact to pain, but the body slightly overreacts to pain a little bit. So in my mind, it works really well with those. So the only problem is now, obviously, it's what we call a controlled drug. So we should only be giving a month's worth out at a time. because it's used a lot in human medicine, human pain relief. And I think they did have some problems with that.
Yeah, I think that's worth clarifying, because that comes up again on Holly's Army quite a lot, where people feel that the vet profession has just changed their minds and they're just trying to be inconvenient or just trying to get more money out of you. It wasn't our decision. It's completely out of our control. This is legislation. We have to abide by this. And I'm sorry for owners that used to maybe get 3 months, a big, prescription bag of loads and loads of, sachets or gabapentin capsules. We're not allowed to. It's as simple as that. We are only allowed to prescribe a month at a time. So sorry for the inconvenience. It's not your vet. It's the rules. Yeah, I use it a lot, and I especially use it if I'm thinking that I've got any kind of like neuropathic-y component.
Yeah, exactly. Yeah.
And I think we're getting better at that. I talk very humbly because I think I've made every mistake in the book. I've been qualified for 19 years now, and I now look at what I know now compared to what I knew 7 years ago, and I just didn't think like this at all. But now I realise it's a lot more complex. I do look to see if I think there's some back pain or there's some neuropathic pain, if there's some sensitization to touch, if there's the behaviour patterns of this is more than just localised pain, this is bigger. I'm thinking that I need to add something on top of my non-steroidal. Do you have the same kind of thought process?
Yeah, and I think one of the things what you just were saying about back pain and things, I think sometimes I notice this, especially acupuncture patients, probably really go through their muscle system. A lot of them, if they're lame on a hind leg or a back or a front leg or something, they will have some discomfort in their back because they're shifting the way their body holds their weight. And just like I said earlier, I had bad back a few years ago, and that sort of sparked my interest. I actually was getting really bad headaches, and that's because you change the way you hold yourself. And I think we have to realise that it's not just one joint, it's the whole body. And they all interrelate, and if you've got a sore elbow, you're going to put more weight on your other elbow. Also, you may be doing something with your mid back and your back legs as well. So you need to be sort of really aware of that when you're sort of examining them as vets, certainly. And also, I suppose maybe pet owners need to realise that's why we're looking at the rest of the body as well, that it's not just that one joint, it's everything that's going along with it as well.
Ian Self, who's a fantastic guy, and he wrote, he's the editor, let me just grab it, of this fantastic book. So Ian Self, who is chief editor of this, he was quoted as saying that if you have arthritis in a joint, you will have pain elsewhere. And he was like, I promise you that there will be some kind of soft tissue discomfort elsewhere, because they're so good at coping with it. We'll come to that world, which I love that world, after we finish your last few drugs. Otherwise we'll tangent off and we won't get to the next ones. Tell me about piprants.
So I couldn't hear you.
The piprants. EP4 receptor antagonist.
Oh, right. It kept breaking.
Sorry.
So this is a new-ish drug. I suppose it's been around a little bit now, hasn't it? A couple of years?
A couple of years, I think. Yeah.
And that's very much more a specific, working on one of the products that you're sensitizing soup to try and reduce that. It works very specifically. It's not a drug I have used an awful lot of, I have to say. I think it's not the sort of patients that I see. So it's more the first line vet that will probably be prescribing it. So it's more from an academic point of view that I've looked at that. And I mean, I would bow to your knowledge clinically of how well you think it's worked.
I think what's interesting is Holly's Army, again, this lovely community group. We had a lot of people that moved onto it when it first came out. So they came off their non-steroidal, so their COX-2 specific, your Metacam, and they went to galliprant because of the low side effect profile and feeling more confident with it. And I would say 50% went back, you know, so after 3 to 4 weeks, they just didn't feel it was offering the same control. And but then 50% were really happy. Again, talking to a lot of your world, the pain specialists, a lot of the cases that you see are dogs that are intolerant to non-steroidals, and the referring vet is struggling to work out how to juggle the drugs they are allowed to use or are tolerated. And galliprant fits in lovely there. But that dog, whether if it had been able to tolerate non-steroidals, would have had even superior pain control on a COX-2.
Yeah.
I think it's part of the talks. I think it's brilliant, you know.
And it may be very specifically whether they produce that particular inflammatory mediator.
Yeah.
We don't know. So that's, and I think that's probably the story with a lot of drugs. It works for some and it doesn't work for others. And it is, although it sometimes looks like you are just trying stuff, what you're doing is working through a list of things and trying to find the best combination or treatment protocol for that one particular patient, and they're not all going to be the same. And that's we know ourselves that we're not all the same. So no. Expect that our pets would be.
And that goes back to that whole concept of the biopsychosocial model. As veterinarians, as practitioners, we need to build this communication pathway that we're confident and allowed to say to the owner, I haven't got a prescribed plan for you that's going to definitely work. I hope it does, but we need to work together and come up with a way that we can be objective and make sure that our chosen plan is working for your dog. And I want you to be confident in me that we can remodel it again and again and again as needed. And hopefully, you know, what with the massive changing world, what with COVID-19, our progression into telemedicine is just gone whoop. I should imagine in the next 6 months, we're going to be rocking telemedicine around the world. And maybe that will give clinicians more time to talk to their owners, because the consult system that we have now is quite tight, isn't it? You know, 10 to 15 minutes to cover this is.
I think that's really difficult for first opinion vet. Really difficult, because how can you discuss what the possible issues are, what can the pet owner do, and diet and exercise and physio and drugs, and what if that all doesn't work, what shall we do? It's virtually impossible to do in 15 minutes. You need a really good relationship with your owner, and you need to have really good communication skills, which, I mean, that's a human too. Not all of them are, you know, they're not all the most natural communicators, and that's, you know, that's just the way people sometimes are, or they might not feel confident enough to, you know.
And also some owners are not the best at communicating. The joke that worked at every single one of the 10 events was, please stop sending your husbands who turn up and just, you say, so what's wrong with your dog? And no, wife sent me. And often it can work both ways. But that's why Cam is here. That's why Cam is here, to try and fill that void, to try and support the vet with their 10 to 15 minutes, encourage vets to start using their nurses, and help owners have home-based education so that they come in receptive, compliant, eager, you know, inquisitive. That's the plan. It's all about dogs. There's a few more drugs. Let's whiz through them very quickly because time is pressing. I've already had an hour of your time. What about the NMDA receptor inhibitors? Where do you see them?
So for me, like I said, I'm a gabapentin person, and then my next one is usually something like amantadine, the NMDA, one of the NMDA receptor antagonists. But if I think that there is a real nerve pain, or that there is, it is quite a severe sort of chronic pain, then that's when I'm thinking about using that maybe a little bit earlier. But it's usually, for me, if gabapentin is not helping them, I start thinking about using amantadine.
Yeah.
It's always difficult to know whether you should have the two or whether you should try one, and will be very dependent on the pet, really, and what's happening with them.
I think cost comes into play.
Yeah,
in my mind, because
and also how many drugs can you actually ask someone to give to a pet? They're not there every second of the day to medicate their pet.
My two cats that live with my parents, they're both 19, 20 now, Eric and Derek, and they're both on Metacam and amantadine, and they're on amantadine twice a day, and a bottle is £350. Yes. Yeah. So it's quite an expensive drug, and they're not more. Not everybody can, which probably gabapentin is a little bit easier to tolerate as an owner as well. Yeah, so it's a little bit more. What about there is the cheaper alternative in there, so memantine. Have you used much?
Yeah. Only a couple of times, just because I've always been more confident with the amantadine and what has happened, sort of research. But I know a lot of the sort of chronic pain acupuncture people are moving more to memantadine, and I think it's just, for us, is knowing what doses to give sometimes, and until you have someone who's checking how the pet breaks that, how a cat breaks that drug down, how a dog breaks that drug down, how much do we give and how often do we give it, and it's very much doing it by case, I think, and judging each of them. So I think you can move between the two of them, and I think sometimes it is just what works better for that.
Yeah, but it takes a relationship with the vet again. It really, really does. Tricyclic antidepressants. My anecdotal N=1, which I actually think we could make a clothing range N=1 for all the academics.
Yes.
But no one else will. I find it really funny. So my N=1 story, Holly, it really made her happier. It did. She had a very huge emotional component with pain, and the amitriptyline, I just felt she smiled more. So do you use it much?
I don't think I've ever used it in a dog. I've used it in a cat.
Right.
In cats. But I also have a story of a human having it for neural pain, for nerve pain. And that was the first thing they reached for.
Yeah.
And it did work reasonably well, very, very low doses. And I think, it's funny you said that your is it Holly? You said that sort of just seemed happier. Sometimes that's what people say when I've done acupuncture.
Yeah. And
they just say, oh, they just seem happier. And you think it's not easy to quantify, is it? But it's always it's one of the amitriptyline is always one of the drugs I have in the back of my mind, especially if I think it's nerve pain, or if I'm not getting on top of it with other drugs. But it's usually sort of lower down my list. But I think it's like, if you have a good experience with one, then you're more likely to use it.
Yeah, absolutely. It's definitely in my like repertoire. But Holly taught me a lot. You know, she could still walk, and she walked in for that final appointment. You know, that she just had a huge emotional weight. It was always there. You could see that her brain was full of it. She was fogged with discomfort. And change subjects. Let's talk about tramadol.
Talk about fogging brains.
Yeah, fogging brain. What's your thoughts on tramadol? It comes up a lot, and
and I said earlier, I don't count myself as a tramadol person. I think sometimes we don't give enough or often enough to have a good effect. Certainly, if it's for real, what we call breakthrough pain, it's not a drug that I would tend to use, because I think it's just not. I think it more changes the way they're perceiving things. But a lot of owners say their dog is just not their self on tramadol. And I know in humans that they can have brain altering effects, that people feel really foggy, they're not feeling, they maybe not quite with it. And I think that's been my experience, but for me, that's very anecdotal again. And usually one of the first things I do is take them off.
You're not alone saying that.
Yeah.
But it does give me a chance to tangent again. So I try and read all the Holly's Army stuff, which is quite big now. And there is a tendency for owners to say things like, well, my vet put my dog on tramadol. He was really woozy. I'm not going back to see that vet again. He doesn't know what he's doing. I've lost confidence, blah, 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 blah. And I sit there thinking, well, actually, that vet prescribed that drug with the best intention.
Yeah.
And it's the fact that that drug hasn't worked well with your dog doesn't mean that that vet's a bad vet. I've had a few dogs that have done really well on it. I've had dogs that have had improved sleep. So I've had owners that have chosen to give it at the end of the day, and they've noticed that they've settled through the night.
And I think that's what I would often say to people. Think about when you're giving something.
Yeah.
Because it will make a difference as well.
And I think people forget that we are allowed to anthropomorphize a little bit. With a bad back, if you're also not sleeping very well, it does just magnify discomfort and pain. So using these aids, in a different way, not just focused on direct pain relief, but thinking about how it's going to improve that dog's being, can have a big impact on pain. There are so many more things to talk about. I want you to come back. Because we've been talking now for a good nearly an hour, and I know what will happen, because there's so much more to talk about, because we've got opioids, cannabinoids, we've got the whole nutraceuticals, we've got the physical therapies, we've got adjunctive. How would you feel that we kind of go, let's stop there, because we're creating quite a monster of a recording? Would you come back? Could I beg you to record again?
Yes.
Second part. Awesome. So Karen Forrest, isn't she amazing? I'm so glad that I wrote to her. What we'll do, we'll call it a day here now. I'll get that up on Facebook, and me and Karen are going to book another date. So we're going to say goodbye. I'm going to press end, and we're going to carry on chatting. See you later, Karen.